Good afternoon, everyone, and thank you for joining us. This is our pre-summit bonus session on the nuts and bolts of a virtual visit. And moderating this session in place of Michael, who has unfortunately had some challenges with a very ill father, Carolyn Rutledge has very graciously jumped in to do the moderation for us at the last minute. And Carolyn is a professor and associate chair of nursing at Old Dominion University. She's a good friend of mine, and she has been a long-time advocate of telehealth and has built a great program out at ODU training nurses and nurse practitioners and really being a great spokesperson for telehealth. And so I think you will really enjoy this session, and I'm going to go ahead and punt to Carolyn Rutledge.
Thank you, Kathy. I am very happy to be here today to present this topic on the nuts and bolts of a virtual visit. You can move to the next slide. And you know, the way today is going to flow is we're going to initially, and I'm going to present a little PowerPoint about some of the issues we have run into with telehealth as a result of COVID-19 and some of the lessons learned. Then we will have a patient that will come on and present their experiences in being cared for through telehealth. There will be opportunity to ask a couple questions there. Then we'll move into introducing our panelists who will be presenting on 3 different important topics that make up the nuts and bolts of the virtual visit. Following that, the panel will discuss the topic and we'll open it up to participant questions. There will be a break halfway through, and so we hope that you will really enjoy our presentation today. Next slide. Okay, as many of you are aware of, we have been impacted by this pandemic called COVID-19 over the past year. It's hard to believe it's been going on for that long. The pandemic has had a lot of impact on our country, but for those of you like me who have been really involved in telehealth for many years, and I've been involved since 2010 when we started developing a program to train people to work interprofessionally together, you know, dental hygiene, physical therapy, mental health, nursing, medicine. So we have been trying to open the door to telehealth for many, many years. Suddenly we have this pandemic occur and the doors swing wide open. And many of us have happily walked through these doors and kind of feel like it's about time. One of the things that occurred, though, as a result of the pandemic were many waivers that were put into place, waivers that allowed you to use equipment that wasn't HIPAA secure. It changed where the originating site might be, allowing homes, places like homes, to be the originating site. It encouraged reimbursement for telehealth services that hadn't previously been reimbursed, and it allowed providers to practice across state lines. So telehealth changed dramatically, and as we know, some of these are things that we don't want to see stay in place long term. We also realized through the pandemic that there were areas where healthcare needed to prepare better, where there were issues that were coming up that were due to the rapid implementation. We found that technology was being developed very quickly to create ways of reaching patients through telehealth. We found that both positive and negative experiences were occurring for providers and caregivers, patients, and staff. Next slide. Okay, so when it comes to providers, of course, with many of the things that happen in healthcare, you have your early adopters and your late adopters. Well, the early adopters were already involved in telehealth, but suddenly people who were going to be the late adopters and maybe not even addressing it for many years yet to come were thrust into having to address telehealth. They came in with very little preparation, if any. They did not understand the equipment. They did not understand telehealth etiquette and the importance of addressing it in a visit. They did not know how to conduct exams using telehealth. The only experience, if they had any, was social visits, like with family members and friends through things like FaceTime and Zoom. So translating that into healthcare was problematic for many people. They also learned how to use telehealth waivers and functioned in an environment where that was the norm. Some of the outcomes there are that many continue to use the waivers and may not even realize when they change. Some providers have become very frustrated and want nothing to do with telehealth, whereas others have suddenly realized how powerful it can be, and they're seeking to grow in telehealth delivery. Next slide. Next, we have our staff. Well, the staff were thrust in as well with little preparation. They did not have to prepare the room, the site, the equipment for a visit. They had no protocols in place. There was a lot of questions around consenting. Do we need to have a verbal consent, or is there a need for written consent? How do we prepare the patient for the visit? What kind of equipment do we use? They also were not trained in telehealth etiquette for when they were interacting with the patient virtually, and had very little understanding of the billing or any of the special coding that went along with that. So an outcome of that is some will continue thinking that the waivers are in place. Some have never learned to bill appropriately. In fact, I was supposed to be on a meeting today where they're very frustrated because this practice has been told, you can't continue telehealth because we are unable to be paid for it. There's some that will, of course, resist working with telehealth. And again, those that have understood its magnitude, its importance. Next slide. And next you have your patient. Again, patients were thrust into the use of telehealth. It became one of the only options many of them had to receive health care. Many experienced visits that were less than optimal, and they became frustrated. Some of that was because they didn't know what to expect. They weren't prepared for the visit. Others experienced very poor telehealth etiquette or felt like they weren't getting any kind of exam at all, and it was not worthwhile. Equipment didn't work properly. The whole process, the flow, wasn't working well. My son, for example, had a telehealth visit, and he got online waiting for it. The provider did not come online for 2 hours. He sat there and waited 2 hours to have his visit. He was totally frustrated because no one wants to sit around for 2 hours when they have other things going on. So there were some unexpected surprises, some around cost, some around the experience. Again, the outcomes, some will be resistant to continuing. Others are going to seek to continue with telehealth because as patients, they really appreciated what it offered them. And they may even leave their current providers and search for providers that will offer telehealth options for them. Next slide. So today, our goal is to help the audience understand some of the issues that undermine telehealth delivery and introduce you to ways to improve its effectiveness and acceptance. Our topics, again, will first be the patient's perspective. Then we will discuss website manner or telehealth etiquette, conducting physical exams through telehealth, and preparing the patient for the visit. Next slide. So this is our panel. We have 3 people that will be serving as part of our panel, as well as a patient. We have Dr. Shruti Chandra from Thomas Jefferson University, who is the Phase 3 director for the Sidney Kimmel Medical College, overseeing the expanded 4th-year medical student curriculum. She's a telehealth practitioner and developer, and the program director for telehealth and digital health graduate certification program. She was also part of the AAMC Advisory Committee for Creating Telehealth Competencies. Next, we have Tina Guston from Old Dominion. She is one of my colleagues in the Center for Telehealth Innovation, Education, and Research. And she is a clinical nurse specialist and teaches in our Doctor of Nursing Practice program. She serves as the director of the center, and this center serves as a telehealth learning hub and research center. She is the clinical manager for the pediatric telehealth program at Children's Hospital of the King Daughters, and also serves on the board for the Center for Telehealth and eHealth Law, or CTEL, and she chairs their Telehealth Education Task Force. And she also worked with me in developing competencies that have been published using the 4P model of telehealth. And finally, we have Angela Skrinsky, and she is a board-certified family medicine and sleep medicine provider, having completed her training at St. Joseph's Hospital in Philadelphia and the University of Michigan. And she serves as a clinical lead for the urgent care telehealth and remote patient monitoring for Virtual Health, the largest healthcare system in South New Jersey. And she is responsible for clinician oversight and training, maintaining quality and safety, and innovating with the digital transformation team, as well as direct patient care through telemedicine. So next we'll move on to Anita Browning, who is going to present us with the patient's perspective. Next slide.
Hi, I'm Anita Browning, obviously, and I wanted to talk about 3 different scenarios that with telehealth that I encountered. And I also want to say this is not only as a patient, but also as a caretaker. Advance slide, please. So I'm affectionately calling these the good, the bad, and the ugly, and kind of want to go through each scenario so that you have some understanding of kind of what happened and why they were designated as such. So the first one is the good, which is a specialist telehealth team session. And this was, I was as a caretaker for my husband, and we were seeing a neurological team that we would see in person, and we would see a multitude of different types of practitioners. Scheduling of something had been ongoing, so that wasn't an issue. For their sessions, when they initiated this, they had a nurse that would connect with us about 20 minutes ahead of time, sometimes more, but they would alert us to this. And so we would connect ahead of time and make sure everything was set. In an in-person scenario, we would have had something similar in that the nurse was the first person that would be coming into the physical room. So this was somewhat congruent with what was happening, what had been happening in person. But it gave a good opportunity to not only address some medical questions, but also to check the connectivity. When they initially began, they were trying to go from one practitioner to another in different rooms with the same connection, and that didn't work. So our first approach, their first approach wasn't particularly successful. And by the time we had our second meeting a month later, they had adapted because they had lost connections in between rooms and things like that. And this is a robust team that we were talking to. So it would be a neurologist, a nutritionist, a social worker, a multitude of people that we were trying to connect with. So by the second time, we were able to what they did is they stayed in one room, and then actually the people who were physically in that clinic would come in and out. So that worked much better. It showed that they were very adaptable when they addressed issues and were responsive. So we were able in that context to see the neurologist and some of the other practitioners, and anybody who wasn't there or would follow up later and connect, and we would have either phone calls or video conferences talking. For example, the nutritionist wasn't physically there, or the social worker, so they would connect with us later. So that is the one that I would have called the good. Advanced slide, please. The bad is I was connecting with a primary care practitioner, and she needed to do a virtual physical so that I would be allowed, according to the parameters of medication, that I could continue medication that I'd been on for 6 years, but she felt that, you know, this was the rule, we were going to follow the rule. And I said, fine, but I'm not coming in, so we can do this virtually. When I was trying to set up the appointment, she had her nurse assistant who was triaging, and I was probably 3 or 4 calls in before we actually connected, and I actually got scheduled a time. They did not have this done through their normal scheduling, so it became a lot more cumbersome because of that. When we finally had our time and our session, the nurse practitioner was turned completely to the side, and she was typing. So her voice was projecting away from me. I wasn't being able to hear what she was saying very well, and she wasn't looking at me. And so for full disclosure, I was a little irritated that we were doing this at all, because other practitioners during the pandemic had given a little more grace to rigid guidelines with medication, particularly if you've been on it for some time. So, you know, I would consider that the bad. There was no real adapting to this, to telehealth. It was taken on with a bit of reluctance. So the approach had left something to be desired. Advance, please. So the ugly. The ugly was a behavioral health therapist who I was seeing, and I had actually been seeing this therapist preceding the pandemic. Because I was a caretaker, I couldn't readily leave for any appointments. So we had started this ahead of time. It wasn't, even then it wasn't going well. My therapist would forget to charge her computer. She would forget her computer at all. And the connectivity was really spotty. Apparently she was using the Wi-Fi of someone else in her office building instead of actually having her own connectivity. And it was strictly on Wi-Fi. So on times where a lot of people were hopping on Wi-Fi, we would frequently lose video. And so it wasn't going particularly well. I was trying to give a little grace to say, okay, this is a learning process and that type of thing. But this was someone who really didn't want to be doing this. It wasn't reluctance. It was more, you know, this is a bother for me. I'm aversive to this. So the approach was not particularly good. Frequently, we would end up not using video because we didn't have enough bandwidth, and so that was something that became an issue because particularly in a pandemic and being a caretaker, I felt particularly isolated and didn't want to just have audio. And finally hit the point that not something I would recommend, but it finally hit the point where I realized that I needed to be a patient advocate for myself, like I had been with other members of my family. And so I I fired my therapist in the middle of a pandemic. So, Carolyn.
Thank you, Anita. So, sort of following up, it sounds like you had the positive was when they actually tried to work with you, and then some of the negative was when they were a little bit less receptive. So, do you have any suggestions that you would like to give to the providers in our audience?
It's not just learning about it, but it's also your approach. If you're approaching this as, you know, a bother and it's too much and you want nothing to be done with it, that approach comes across. There are always going to be frustrating times in telehealth where something doesn't work. But if you kind of work your way through those issues in order to try to provide the optimal scenario for both provider and patient, then, you know, that would be the best.
Okay. What about staff? Are there things that they might have been able to do to prepare themselves or you better for the visit?
Not all of these scenarios had, yes, to answer your question. The second scenario particularly, I mean, I felt like that the primary care practice had made poor decisions on making sure that someone else had to triage everything. That may have sounded good on when they went through it, but it didn't work out from a patient perspective because there were multiple calls.
Could I have our panelists come on screen? And I was wondering if they had some additional questions for Anita.
Anita, it's Tina, and I have a question. We are all evaluating our patients after encounters, whether they're in person or telehealth, and most of these surveys are sent out to them. One thing that I believe that we should do at the end of every visit is ask, how did that go for you from a telehealth standpoint? So while it's fresh in your mind, I mean, we are also learning as we move forward. Did they ask you that at the end of your visits?
Certainly didn't the second, certainly didn't the third. The first one I volunteered, so they didn't get a chance. And I am in somewhat a unique position because I work in telehealth, so I knew what should have been happening. So it, you know, but no one, I was never surveyed at all. No.
Other questions from the panelists? Okay, so I think some of the takeaway from your talk is that it was the characteristic, it was some of the behaviors that could make even a bad encounter go well. So it really came down to the person's attitude and their way of relating to you. So you could look past some of the difficulties if the person was being gracious about it. So, well, Anita, thank you for your input, yes. And we will be getting more information from you, hopefully, as we go through the other panel discussions. So I am going to move on to the next presentation. And that presentation is going to be delivered by Angela Skrinsky. And she is going to be talking to us about website manner, or what is also known as telehealth etiquette.
Thanks, Carolyn. And Anita, thank you so much for setting me up so well, because you talked about a lot of the things that can go right and wrong in a telehealth visit. And so I think that a lot of what we'll cover today we'll talk about the same. And so I'm speaking now from the perspective of a clinician and hopefully demonstrating how we can make things better for our patients. Jason, do you mind advancing the slide for me, please? Thank you. So webside manner, otherwise known as the equivalent to a bedside manner in telehealth. is different from a bedside manner in some ways, and yet there are other things that remain consistent. So certainly the medicine doesn't change. When you're working in person or delivering medicine via telehealth, that stays the same, as does the visit format, the goals of the care and the interaction. So the patient and the clinician still both want to build rapport, feel comfortable, transfer knowledge between one another. Those things don't change. The parties involved, the clinician and the patient, that doesn't change. But what is new and what does require adaptation is you're using a whole new care delivery model. You're likely using some new software. The patient is in a different environment. The clinician may or may not be in a new environment. And your access to support staff, equipment may be different. Most certainly, the physical distance between the clinician and the patient is different, which I'm sure that we'll talk about more when we talk about the physical examination. And last but not least, anxiety is heightened in patients and clinicians who are relatively new to telehealth, and add in a pandemic, and that makes things a little bit worse. Jason, if you can go to the next slide, please. Thank you. And so what I like to think about, if we have the goal of providing and delivering excellent website manner, how can we achieve that? So I like to think about a telehealth visit, splitting it into 4 pieces. And I like to think that if we can achieve excellent website manner, if we can do a few particular things in each of these buckets, that we'll have delivered on our promise for excellent website manner. Jason, these are transitions. So if you don't mind just clicking through this slide. So I feel like if we can prepare well for the visit, open the visit well with the patient, build rapport throughout the visit, and then close out with a bang, and one more button there for me, Jason, then we will have delivered on excellent website manner. And next slide, please. So before we even start the visit, there are things that we can do to set ourselves up to deliver an excellent telehealth experience. And those are things like very basic things like lighting, making sure that you're positioned in the center and close to the camera so that the patient can see you clearly, see your gestures, see your facial expressions. You want to, of course, make sure that you're wearing professional attire, that your background is professional. Same kinds of things that you would do when seeing a patient in person. Also want to make sure that you know how to navigate your software and simultaneously your video software and simultaneously your EHR platform. Those things are all important to do prior to the visit to set you up for a good visit. And one thing I've noticed here, there are tons of videos on YouTube that you can look at for website manner tips. But who does this the best? It's your TikTokers and your Instagrammers. They know how to position themselves in the camera, make the lighting right so that you can really see them well, and it's closer to an in-person interaction. So I would direct you to them, to our internet celebrities for tips on this portion of telehealth. Next slide, please, Jason. So when we then begin the visit with the patient, it starts out similar to an in-person visit in that you make your introductions or you make your greetings. But there are some facets that are different. So one is that the patient is no longer in the controlled environment of your office. So one thing that you want to do is ensure that the patient is in a private location and a safe location. I'm sure many of us have stories of patients trying to have telehealth visits when they're driving or in public places where many other people are around and can hear their confidential information. So part of that onus is now on the clinician to make sure that the patient is in a controlled environment. Additionally, you'll want to make sure that you're obtaining consent from the patient to do a visit via telehealth. I find it really helpful to also ensure that the patient has a good connection. So, can you hear me okay? Can you see me okay? Great. And then I like to confirm in turn, and I can hear and see you well also. This is also the time that I take in the beginning of the visit to let the patient know how they can connect back with me in case we lose each other during the visit. And I think that's important, to reduce the hesitancy, the anxiety, the fear, and kind of put control back into the patient's hands. Next slide, please. Then as the visit progresses, you're going to continue to have your interaction. And in addition to the content of what you speak about, you can build rapport by making sure, now remember, the patients can't see your full body anymore. So now they're really focused on this top half, your face and really some of your shoulders. And so they're really dependent now on your facial expressions, your hand gestures. Those are going to be really important to convey to the patient the same emotions that you would have conveyed previously in other ways. So you want to make sure that that you're conveying what you want to convey: empathy, support, hey, questioning, give me more, tell me more. That's really becomes very important now. Eye contact is a tricky one. We know that patients prefer when we make eye contact with them. However, as many of us know, when you're doing a telehealth visit, if you are actually looking at the patient on the screen, which is part of our job, right? Because we want to be doing an evaluation of their mood and their affect, their general appearance, etc., then we're not looking directly at the patient, or at least it doesn't seem that way. We're not making eye contact. Additionally, if we're focused on our EHR, documenting, looking at the chart, we're not looking directly at the patient, because looking directly at the patient means looking into the camera lens, and that's hard to do and do all the other things that we need to do at the same time. So on this point, I usually will communicate to my patient, I would love to make eye contact with you throughout our entire visit, but I am going to occasionally break that eye contact to either document or look something up in your EHR record, or simply to examine you. Next slide, please. And I find that that works really well. They're very adaptive to that kind of a thing when they're told in advance what to expect. All right, so now once the patient is really feeling comfortable with this, we want to wrap it up, tie it up in a nice little bow, make them feel good as they seal up this visit. So, you review the plan of care. That's really not different from an in-person visit. You answer any questions that they may have. That's not very different. But remember that you can no longer hand them an after-visit summary. So you want to give them an idea of where can they access everything that you just talked to them about: their notes, their chart, their after-visit plan. How can they schedule whatever you've just asked them to schedule, since they can't do it at the front desk anymore? I also like to tell patients how much work we're doing on their behalf. So tell them, hey, I'm also routing this note to your PCP or to your cardiologist or what have you, so that they can review it as well. That'll allow them to see the benefits of technology in medicine. You want to provide them with your contact information, how they can get back to you, or how they can escalate care, which may be different now that you're no longer in person. And as we've already talked about with Tina, requesting feedback is important. I like to close out my visits by waving goodbye, which gives a really nice physical signal that the visit is ending. And then before you end, you want to keep your smile on as you hit the end button, so that the last thing they see is not, a grimace or you moving on to your next portion of the day. Next slide, please. And I think that's going to bring us to our discussions. I hope that I triggered some ideas and opened up some good thoughts about website manner for everyone.
Thank you, Angela. And if we could have the rest of the panelists turn their cameras on. One of the things that's great about our group of panelists is that they're all experts in these areas. So we want to get a little bit of input from each of them as well. So are there any comments that any of you want to share before I ask you some specific questions?
That was a great presentation, and I think everyone on this panel knows that I love etiquette, and that's a passion of mine. What I found is pacing is so hard, and with the telehealth encounter, I think some providers really start rushing, and it's a very mindful process to pause and to wait for the question, and it's just a different skill.
I absolutely agree. I think giving space and silence is much easier when you're in person than when you're staring at a video. And so that's something that is very important. And as you said, it's a mindful process where you have to make the effort for sure.
Mm-hmm.
I know one of the things that people tend to struggle with, and I think it falls under the category of telehealth etiquette, and that is doing things to create an environment where the patient feels like there's empathy. Do y'all have some suggestions on how you can do that within a telehealth encounter?
I think one of the things that Angela said is very resonates with me is also it's not just the encounter, it's the follow-up. And in my second scenario with the primary care, the pièce de résistance is they mailed me a prescription. So I am waiting weeks to schedule and everything like that, and then they mailed me a prescription. So I think that the follow-up and it is part that a lot of people have been not focused on, but needs to be addressed.
Mm-hmm. Other thoughts around the whole empathy issue?
There are a few questions coming in the Q&A.
Yeah, we will get to that in just a minute.
Okay.
One of the other things that I know people are looking for, people, like I said, are flying by the seat of their pants. What are some resources out there that you think that you're aware of that you know would be beneficial for practices and providers to utilize to help them with the telehealth etiquette?
You know, it's interesting, Carolyn, because of the recent boom in telehealth, this has become a really hot topic. And so there are, honestly, you can just do a Google search. There are tons of those on Webside manner. Some of them are, of course, better than others. There are some written documents as well. And there are now also consulting companies that will come into your institution and provide classes to your clinicians on how to provide excellent website manner. And then they will also do things like physical examination, optimizing your workflow, etc. So it's really a whole business surrounding this now. And I anticipate that we'll see a lot more of that sort of thing to come.
Along that line, do you know of any AI type platforms or ways they're using it so that people can go online and just learn about their own etiquette?
I'm not aware of anything like that. That sounds pretty cool. You're starting a business, Carolyn?
I'm grinning because we're working with somebody developing a platform like that because, you know, it's interesting that it has become a business now. Several years ago, when we first started talking about etiquette, you'd get a blank face from a student or a physician or a provider that was like, what do you mean you're teaching me etiquette? I know how to do that. You know, I'm a provider. And they didn't, it was hard to wrap their brain around the subtle nuance that's needed with telehealth. And then with the advent of Zoom 24/7, we've all seen bad visits. And what we're talking about is a platform that you can see your eye contact and you can, you get feedback immediately in your body movement that may be kind of an irritating, distracting movement. Because it's hard to be told you're doing a good job or you're not doing a good job because it's very subjective. But to get that back from a computer system that's AI telling you, hey, look at the camera, or tell, to your point, tell your client or patient that I'm going to be looking down charting, and that's okay.
I think it's interesting that this is not the first time this has come up for feedback. I do a lot of coaching for students during their interviews, and a lot of those interviews turned virtual this year, and in the past they've had to do that. And so there have been other programs and applications that the students actually record themselves. They get feedback about their performance. And I think the easiest thing that you could do before, until all of these wonderful AI programs do come around, is really just record yourself talking to a patient or pretending to talk to a patient, whatever that may be. And you will easily be able to pick out yourself what makes you comfortable and what made you uncomfortable when you were the patient to your own provider. And I think that works, just simple solutions.
Well, thank you. What I'm going to do now is go to some of the questions that we have posted. We have one from Nora King, and she says, how do you handle safety issues, such as finding that a client is involved in a domestic violence situation? You cannot be sure that the perpetrator is not in the house. Don't all answer at once.
It's a difficult question, which is why I think we're all sort of pausing and waiting. I suspect that every institution has their own approach to how they might be handling these situations. For me, I am trained as an emergency medicine physician. So I'm always a little bit keyed into, is this some kind of situation where I need to call 911 and send them over to their house, or I need to do something that can help save this patient. And I have done that before, not numerous times, but enough that, that we have a protocol for it. I think the more important part of it is recognizing that there's a problem, because once you recognize it, you can call the local police department, or you can call somebody to try and help. So I think the recognition is the difficult part of it. Interestingly, for the patient, being in their home environment gives you a lot more clues than when the patient's in the office. So I think recognition is actually aided and much easier when you're on a telehealth visit than when you are just in the office trying to decipher the clues that are outside of their home environment.
Any other comments on that one? Okay, the next question is, what do you do when clients are involving others, when others in the house interfere with the session, when they're in a public setting? Oh, that public setting's a biggie.
I would say that that's part of the preparing the patient, which we'll have at the end of this session, is letting them know that if you're a caregiver, like Anita, that it's appropriate to have other family members there. But plan your visit for who's going to be with you during that visit and who's going to be outside of the room to have the door closed. And that's preparation. And when you don't prepare is when you have people walking behind the patient with their underwear on, going back and forth from the shower to the bedroom, which truly happens. Does anyone else have any suggestions?
Yeah, we also have an OA who initiates a video chat with the patient at times. And so we have some scripting regarding, if the patient is in a moving vehicle or something of that nature, something that they can tell them. Also when we're doing a sensitive examination, you don't know that you're doing that in advance of the visit. So then during the visit, when I know that that's what we're going to do, I'll ask them to just check the windows in the area, make sure that they're comfortable and that the door is locked, or whatever it is that they feel comfortable with that ensures their privacy.
Okay. Another question. How often have you had to spend significant time with a patient to have the good video connection? Or did you have someone ensure this was a good connection before you joined the visit?
A lot of the video platforms do offer a test. Actually, you probably did one today with Remo, which is really helpful, but there are other platforms that won't have such things. And I have, depending on what we're using, I have at times spent a good amount of time working on a video connection. As clinicians, we're doing this for most of us all day long. And so we have our setup and we're good to go, but the patient may not have the same access.
I think part of the preparation too is to make sure that the patient does do that check, because you can bypass the check. Just to remind them, even if you've done it, even if you did it last week, do it again this week. The connection may not be as stable.
And I think another thing for scheduled visits is that you can, especially for the first time, perform test calls and things like that. So if you have the resources and the staff to be able to reach out to the patient, do a test call, make sure everything works beforehand. And if you have those resources, I think that would be the smoothest way to ensure a good connection.
You got a compliment. Somebody likes the idea. This is Mary Devaney, likes the idea of holding your smile through the end of the session. So I like that as well. And she also mentioned that with patients that might be in tough situations, that you might want to establish a safety phrase with them so that they can say that phrase and you know that they need help. Then do you have rules that have been set up regarding clients involving others in the visit or when others are in the house and interfere? I think that goes back, to the preparing.
Yeah. The biggest one that sometimes comes up is asking people to turn off their television. I mean, it may be something they have on all the time and they're not thinking about it, how it's going to be in this context. I mean, because I was guilty of that. I was like, oh yeah. So.
Okay, now there's a question from Diana Vice Posh. What are your experiences regarding training the provider staff for understanding telehealth, scheduling, pre-visit, billing? Again, I think this is probably going to come out more in your talk a little bit later, Tina, correct?
I mean, part of the talk is certainly, this is not a one and done. It's not just the provider. You know, when you roll out a telehealth program, your schedulers need to understand, your clinicians, your nurses. It really is it's a team sport, and everyone needs to know that telehealth is an option in the practice. And I will talk about it a little bit more, but something as simple as when you're visiting with your patients in person and you know that this is a chronic condition or a condition that lends itself well to telehealth, everyone in that practice should be talking about telehealth as an option, you know, so that they hear it from the scheduler to the nurse to the provider and then back out the door.
One of the things, another question for you is that a lot of times you need to, and you're aware that providers that you're working with or staff need to learn about telehealth etiquette. How do you go about approaching them and getting them to move forward with any kind of training or adapting it?
From my perspective, I think simply you make it a part of everybody's and not singling someone out, and everyone gets trained and does the same training and gets the training for the etiquette and training for the things that they had mentioned, the workflow, etc. And you treat everybody exactly the same, no matter how experienced a physician they are or they may think they are, or how inexperienced a provider they are. I think you make it the same, make it equal, and that's how you get everyone on board.
Yeah, I would echo that. Absolutely.
So just across the whole practice training, this is just part of what you need to do. Because I think this is the one thing that people have just taken for granted that they know how to do, and they don't realize that they need to delve a little bit deeper, that even lighting, jewelry, clothing colors, all of that can have a huge impact on the success of the visit. So it's
setting standards. Yeah, setting standards that go across the board. I mean, you do not take a call from your phone when all your patient can see is your nostrils.
I'd like to make the point that Anita left a provider that she had been with for some time. I would imagine it was because of the etiquette. And we've been saying that for a while now, that you can be a fabulous provider, but if you can't transition that to telehealth and your etiquette is poor on telehealth, people will leave.
Mm-hmm. Okay. Any final thoughts about the whole topic of telehealth etiquette, or anything that you think we might have overlooked that the audience might need to know about? And again, you know, I recommend that you look at some of the resources out there. There are some amazing ways of training your staff between videos, you know, just simulations between several different providers within your facility, where they're giving each other feedback, their evaluation tools. So there's a lot of information out there. There's also articles that I think it's important to look at to really recognize all the components of telehealth, and sharing that with some of your staff as well. So, okay, everybody can take about maybe about a 10-minute break until 3 o'clock and stretch, and then we'll come back and we will do our next two sections. Thank you. Okay, welcome back. We are going to move on to our second presentation, which is on conducting the telehealth physical exam. And this portion will be conducted by Shruti Chandra from Digital Health and Telehealth Education at Thomas Jefferson University. So it's all yours, Shruti.
Thank you. Thank you very much. So, as Carolyn suggested, there's a couple of things that we're going to talk about for our nuts and bolts of this visit. And I think one of the things that comes up a lot is exam, the telehealth exam. So can you examine a patient? I think I put it up on the screen. Yes, you absolutely can. I think one of the biggest myths of telehealth has always been that you cannot perform an adequate physical exam for a patient. Providers are uncomfortable with never actually laying hands on the patient. But if you think about it, you can glean a lot of information through video for a complete visit. You can, in fact, perform a level 5 physical exam through telehealth if that's appropriate for the type of visit that they're coming in for. I think one of the things Angela said very well is to remember that the medicine does not change. It's just the way you deliver it, and telehealth is just a tool to deliver it. So first thing to remember is that 95% of the diagnosis comes from the history of the patient. Oftentimes, when I walk in or when you walk in, you know the diagnosis even before you perform the exam for the patient. The general appearance of the patient provides you with many clues that you will need to decide if this patient is appropriate for telehealth at all or not. As an emergency medicine physician, when I walk into a room, the first thing I figure out is, does this patient look sick or not sick? And your gestalt as a practitioner is really very valuable as you try to come up with treatment plans for this patient. Even in person, inter-rater reliability of a patient physical exam is fairly questionable, and it really depends on you as a practitioner, you as a provider, and what your skills are with the patient. Additionally, I think I mentioned this previously, you get a lot more information with a telehealth visit when you compare it to an office visit. You get to see how the patient lives in their environment. You get to see if there's a lot of staircases that they have to climb, what their house looks like, where their medications, are they living alone, etc. And so you get a lot more clues as to this exam of this patient than you would when they are in your office. Next slide, please. So how do you perform an exam? Well, you're able to visually assess the patient on video, just like I said, and you can see, are they ill? Are they not ill? Are there some very obvious visual manifestations of their disease? Are they very obvious deformities or other physical exam findings that you can see? A patient can actually also perform a lot of it by themselves. For example, they can perform an entire neurological exam without you having to be present next to them, including checking their cranial nerves, range of motion of all of their extremities. May have them perform a cerebellar exam without having to be there. So if you start to think about what you do in a physical exam, you can start to think about how you can extract that on video. It's also helpful to use the resources you have in the room, such as your caregivers or your families. They are able to assist in the exam. They can palpate an abdomen. They can provide any resistance on a musculoskeletal exam, and all you have to do is coach them through it. You're also able to use any adjuncts and patient's own devices. Everyone seems to have a smartwatch or a smart app that can give you a set of vital signs. They may have a blood pressure cuff at home. They may have a weighing scale at home, and patients can provide that information. For example, if you're worried about heart failure complications. And in the time of the COVID pandemic, a lot of your patients actually have a pulse oximeter who can give you this information that might be important for respiratory complaints. So I want to show you a short video of an example of an abdominal exam for a telehealth visit, and you can see what they use, where they can instruct the patient to do the exam as well as a caretaker within the room.
So it's right in this area here.
Okay. All right, perfect. Now, if you use your right hand and you touch underneath your ribs, do you have any pain?
Nope.
Do you have any pain in your lower belly on the right-hand side?
No.
Good. And how about kind of at your belly button or below your belly button?
No pain there.
And how about on the left-hand side?
Nope.
Perfect. Now what I'd like to do is I'd like to ask you to jump 3 times. And that is a sign for me of whether or not you have something really bad going on in your belly. Can you jump 3 times for me?
Sure.
Perfect. Now I'd like you to lay down on your couch over there with your knees up. Perfect. And bend your knees at 45 degrees.
Okay.
And is your roommate Greg there?
Yes.
Hey Greg, it's Dr. Kleiman. Can you help me out a little bit with the exam on the belly?
Sure, no problem.
Perfect. What I want you to do is I want you to take 2 hands on top of each other, and I want you to gently palpate, first starting in the upper right part of Nick's belly. Can you do that?
Okay,
Yeah, I can hold this if that's easier.
so take 2 hands.
Perfect. 2 hands on his right-hand side. Perfect. And I want you to push down first soft,
Okay,
and now a little bit and let go. And now push down a little bit deeper and let go. Nick, are you having any pain with that?
No.
Perfect.
But what he did, our wonderful physician, was to instruct the patient exactly what he wanted, show it on himself on video to show what the upper part of the abdomen meant, what the belly button was, etc. One of my favorite things is to ask the patient to jump up and down, because that's a very quick trick to figure out if there's any peritoneal signs for that abdomen, and that will give you a very quick clue as to if this patient needs further involvement or further evaluation in person or not. And then he used the roommate, the person that's in the room, and instructed them exactly how to do soft palpation, deep palpation, rebound, and guarding. So it's a lot of an exam that you can do on video just by going ahead. Let's go back to the PowerPoint presentation, please. So you can get most of this relevant information on an exam to take treatment plans for conditions such as abdominal pain, heart failure, asthma, COPD, back pain, et cetera, et cetera. As you can see, I went on and on because there are so many things that you could get the information from. Here's a quick list. Here is some key findings for a back pain exam when you're performing a telehealth physical exam visit. So you can take a look at these as they come up on your screen right now, but notice that a lot of these findings you can do on video without any issues and without any problems. So this is just one more example of performing a physical exam through telehealth that can be performed without being in person with the patient. Next slide, please. So there's a few other extra considerations that need to be taken when dealing with your patients, particularly if you're thinking about private or sensitive exams. And topics such as a GU exam or a breast exam, you may need to have a few more etiquette and privacy considerations. You may want to think about having a chaperone or not, depending on what your patient is comfortable with. So far, we've talked about direct-to-consumer care, meaning the physician directly interfacing with the patient. But if you are, for example, performing consults with a patient in a remote office, or if there's a telepresenter, which is just another person in the room that may have some sort of training, then you could actually have them have a lot more resources on hand and perform the exam or help you perform the physical exam. For example, our sister sites that use the Jefferson Stroke Telehealth system always have a physician in the room who can assist with the exam and provide vital signs, etc., to the consulting neurologist. And this system has been going on for more than 20 years. So there are other considerations, but in the bare bones, without any other extra technology, without any other people, here's how you could perform a physical exam. Next slide, please. So how do you convert any resistant providers, or how do you provide confidence to those that are a bit hesitant? The answer from my perspective, and I am biased because this is my background, is education and training, onboarding. We have developed multiple physical exam videos to train our own providers, and you can use them or you can use your own. And I know many on this panel also probably have their own versions of this. So feel free to use your own videos. Sometimes it's better to use your own specialists and your own experts because that gets you more buy-in from all your different specialties and providers that you're trying to train. We've also created checklists and pathways that you can follow along for virtually any chief complaint so that they can assist you with important physical exam findings that act as reminders. The more information and the more support you can provide to your providers, I think, the better. And lastly, I think we need to start early, which means I think we need to start in training because the providers of tomorrow are going to need these skills. Telehealth is not going away. So I think we need to start to think about training our students and our residents and our fellows to have these skills, not just telehealth physical exam, but etiquette and preparing the patient and all of the other topics that we're going to be talking about. So with that, I'm going to pause and see if we have any questions and bring Carolyn back out.
Thank you. Thank you for that great presentation, Trudy. So doing the physical exam without equipment, it's a novel idea to many of the providers out there. I keep hearing providers say, well, we can't do that unless we see the patient. And I think that was part of what Anita was alluding to in her presentation, that she ran into situations where they wanted to do the physical exam face to face and were resistant to using the technology. So as you think about moving in these directions, the videos are definitely an excellent way of educating providers. Are there other techniques that some of y'all have used to help educate providers?
I think the checklist would be something that could be really helpful. And this is my, not as my patient hat, but as my matrix outreach hat. A lot of the things that I've been learning as I'm watching webinars is kind of to teach, be it palliative care or whatever the scenario is, to teach them to have a checklist, to incorporate things that you might not think of. For example, in palliative care, it never occurred to me that, when a nurse would walk in, looking at the feet would be an important thing, and they wouldn't necessarily, and if you have a checklist, you can address that. So it's trying to translate what may have become habit in person into a virtual context.
Yeah, and so that sort of ties back to what we were talking about previously about the need to have protocols. And so protocols for certain types of telehealth visits could be very helpful. What about other ways of making sure the physical exam occurs? Or that you know how to?
I'm going to put my academic hat on now, like several of you on this call, and I would say virtual precepting. so that if your resident or your student is remote and you're remote and your patient is remote, you go in together. So you are precepting them virtually, and they can truly learn the technique in a virtual manner.
I think you brought up such a great point. We talk a lot about how do we assess our students as they're performing their telehealth visits. And I think three-way calls are so convenient and also gives you that insight. I mean, it's bedside teaching at its finest, except it's telehealth. Exactly, it's virtual. And I think it gives you such an opportunity to be able to watch them do an exam, do a history, counsel the patient, and really give them real-time feedback, right after the visit. So you brought up a great point. Yeah.
Have any of y'all worked with any simulation activities to help people learn how to properly do physical exams?
Yeah, I in fact, one of the courses, as you mentioned, that I run, we do practice visits with the patient, with our students, and we get them to perform a physical exam and do the whole visit and then give them feedback. Actually, there's two ways that we like to do this, and I get them to do it to themselves so that they are their own patients or each other's patients, and they give each other feedback, and then I watch them as the provider, as the teacher, and then give them feedback as well. And so you could perform simulations with standardized patients, but I think doing it to each other gives you a unique insight when you are the patient as well.
I think that's important in this time of COVID when we don't have as much access to standardized patients. Tina, you had some comments?
I was going to say we have a similar way of teaching our students in one of our courses where they rotate through the role of patient, provider, and evaluator. So they each have that role throughout the experience, and it's rich to be able to experience it as a patient, do it as a provider, and then also get that critical feedback and just learning how to give feedback.
So with that, the students that aren't the patient or the provider or evaluating the performance of the
Right. And we have it set up in two different ways where one student is evaluating the etiquette and the other student is evaluating the assessment. So they really can focus on one aspect of the visit. So there are 4 students rotating or participants.
Okay. So it's kind of exciting that we have these opportunities where we can actually do the training through some of their virtual platforms. So again, one of the aspects of telehealth, provider training. So excellent. And so I know that Shruti, y'all have educational programs along that line, and I know we do at Old Dominion as well, certification programs. So I think that's important as well. Are there other things that you think you need to let the audience know about the conducting the physical exams, or do you have any comments about the physical exam and the inclusion of peripherals? I think some of us are getting so used to doing the exam without the peripherals, we're beginning to wonder if we really actually need them.
Yeah, it's interesting. A lot of times you don't, but they definitely add something, and they certainly expand what you're able to evaluate in a patient, right? So, a Bluetooth enabled otoscope to see an otitis media, I would say that's my biggest pet peeve with telehealth, because it's like, that's something that's just like a hard stop. You really cannot rule it out. Pulse oximeters have been invaluable with our COVID-19 program. So there's certainly a value to those things, and they don't necessarily have to be, uploadable per se, Bluetooth enabled, etc. They don't have to be connected. Patient can certainly show you their pulse oximeter, can show you their blood pressure monitor. And there are times that we troubleshoot, okay, turn the blood pressure cuff around, things like that. So it's really, when you start doing telehealth, amazing how much you can do and how flexible you can be.
I would also add to that, outside of the physical exam, but as you're thinking about your patients that have those devices at home, not peripherals, but the devices that they have to care for themselves, it's an excellent opportunity to evaluate whether they're using them correctly. So often they'll come in and give you data and it's not valuable because they're not using it correctly. And you can see how they're, to your point, how they're putting the blood pressure cuff on. You can walk them over to their medication cabinet and see what they're taking. And it's just all an invaluable part of your physical exam. You can see the cat in the background. That why are they still wheezing? Well, there's a cat walking by.
I think I love it. The pets are so, no one ever thinks about it, and that's the problem. And to that point, you can watch them know how to take their sugar, how to take their insulin. Are they using their inhaler appropriately? There's so much that they can do. I was going to bring up that what Angela said about using those peripherals or getting information from the patient and what they use. There's, I think, going to be a lot of conversation about how do you report that data and how do you document that, and where does that go, and what does that work? I don't think we have the answers to that, and we definitely don't have the answers to if that's billable or not. But we definitely, what I suggest and what I recommend is that if you start to see and use peripherals, that your institution or your practice should have some sort of pathways, or at least some sort of guidelines as to how to report this information and where to do it and how to do that appropriately, at least until there are any more broader national conversations that decisions that happen.
And we've got some questions from our participants. One is to you, Dr. Chandra. Are the videos and checklists you mentioned available on the Thomas Jefferson website?
Yeah, they are. And a lot of them are actually short CME courses. Most of them are for outside people. And then within Jefferson, we do have training for all of our providers, because that's kind of what we do. Same thing that we said, every person gets the same training. I can put the website in there, but it's jefferson.edu/telehealth. Make it easy.
Okay. In addition to webinars and videos, do you think having someone available, experienced, spend times hand-on with providers for a period of time prior to a solo encounter would be helpful?
So I can say from my perspective, the rapidity with which we had to scale up during COVID-19, it would be and was completely impossible for any one-on-one in-person training. And we found that just because we had a lot of these resources available, it was easy for us to deploy them to a large group in a short period of time. And we were able to train physicians and APPs and other providers probably within 24 to 48 hours, because we could do that. Now, does that mean that hands-on training is not helpful? It absolutely probably is. I just think that the way that a lot of us were pushed into doing this, it was just impractical. I don't know if anyone on this call actually did that or are doing that right now.
No, I would agree.
Okay, another one to Dr. Chandra. For the early start, if you were just starting such a program, would you start with a fellowship, residency, or with medical students? Is there a logical priority that leads to success?
That's such a good question. So I always used to think about education in that process, students, residents, fellows, faculty, et cetera, and then gaining competencies as you moved forward. But telehealth really puts a wrench in that, because some of your experienced providers may be terrible at telehealth, whereas some of your medical students may be much better, especially because they're just more comfortable with the technology, more comfortable with your Instagram and your TikTok and with that etiquette perspective of it. So I don't think there's a great, I think it's difficult to identify who would be good and facile at these skills versus who wouldn't. And so even though this sounds like a large undertaking, I think doing it for everyone around the same time would be the best. And right now, I think the same level of training for everybody is probably appropriate. But then as you move forward and your students become residents and then they become fellows, that's when you can start to dial up the level of training and the competencies, and the training gets advanced more. I think right now, everyone's at that basic level. Everyone gets the same thing no matter what. And then hopefully in 5 years, when your first class graduates and you move on to do whatever it is they are doing, then you can start to think about advanced training.
I want to expand that question, because that was focused, I think, a little bit more on our physician providers, whereas we have a wide range of other providers. And I know, Tina, that's an area where you have worked a lot. What are some of your thoughts about education, who needs the education, and how to proceed with it?
I'm not sure the direction of the question that you're asking, other than nurses and telepresenters need the education as well. They don't need to know how to conduct a physical exam, but again, everyone who's part of the telehealth program needs to be trained. And what I'm seeing, to your point, are nurses on the floor who have not been trained in telehealth, so they don't even think about telehealth as an option. So when you're pushing this out at an institution, it's not just the telepresenters, it's not just the providers, but it's really everybody needs to have some sort of introduction to telehealth, what it is and how it may leverage their practice at the bedside, or even in a management role. I mean, it crosses all roles in all professions: physical therapy, speech and language, nutrition, dietitians. So was that the right answer?
Well, yeah, and that's heading into it. And I think one of the things that you mentioned that is very important, and it goes back to what started me in telehealth to begin with, is the fact that telehealth can be such a phenomenal platform for interprofessional collaboration. Right. Really bringing in, you might not be doing the physical exam, but you might be connecting your patient that has a neurological problem with a neurologist, where you're there, the neurologist is at a distance, and he is actually doing the exam, and you are the one that is facilitating it.
That needs to fix the lighting and close the door and put the sign on the door, and
might be having the patient smell things, might be actually, as opposed to a caregiver or a friend that's in the room, the provider might be the one.
It's such a team sport, absolutely. And I think everyone in that team needs to be trained, just like any other interprofessional team.
Absolutely.
Right.
Yeah.
And I think that's an interesting area of education along this line, is the interprofessional connectedness, where you provide education with the different professions together. So you're also breaking down some of the barriers to the various disciplines. So,
which really leads to the next talk on preparing the patient, because who is the center of an interprofessional team but the patient? Mm-hmm. And so if we're teaching telehealth, we need to teach the patients as well.
Right. Okay, there's one more question. How about hybrid models of care in which telehealth, home care, rehab, mental health service, etc., can be part of the patient treatment plan simultaneously?
I think all of us can say yes. That's a great idea, and I think that's exactly where we shall be moving towards. And once we start to get a little bit more facile with all the skills that we have and all the tools that we have at our fingertips, that's the perfect way to do it. Where you have a hybrid model, where you bring them in when you need to, and you use the skills and the tools that you have when they're at home. It would be perfect.
Mm-hmm. And I think that's also part of what we run into with the Project Echoes as well, an opportunity to bring in other disciplines as well.
Absolutely. Mm-hmm. And community resources. I mean, everything.
Mm-hmm. Right.
Yeah.
As you said, it's a team sport. Okay. Well, thank you for discussing the topic about physical exams. And so now we will go on and move to our next topic, and that puts Tina Guston. says Tina Sweeney.
Got my middle name up there. I just like throwing you for a curveball.
I know, and you know I like to read. Okay, so Dr. Dustin is going to speak on preparing and engaging the patient in the telehealth visit. This is an area that hasn't quite had as much focus in the past, and I think it's something that we really realized as a result of the pandemic. And again, Tina's director of the Center for Telehealth Innovation, Education, and Research at ODU. So Tina, take it away.
Certainly. So that was a great segue into this particular presentation, thinking about the patient as the center of the care model. And as we're educating and preparing everyone for telehealth, we can't forget about the patient. You know, prior to the pandemic that we've just lived through, our patients that were using telehealth really chose to use telehealth. They were early adopters. They were comfortable with technology. It might have been your millennials or just people that were used to FaceTiming, and this concept of telehealth didn't concern them or scare them. Clearly, in this past year, telehealth has been thrust to not only providers, but towards patients. So let's go to the next slide. And as an educator, I'm just going to go over some objectives that I'm going to touch on over the next few slides. You know, why is it important to announce the availability of telehealth? How do we assess whether this is a patient that even has access to technology, understands technology? How are we going to set them up for this visit, prepare them to troubleshoot? I think that was one of the questions that one of the participants asked earlier. And then etiquette is real for the patient as well. So let's go to the first slide, please. And you will have access to all of these slides afterwards, so I have been a little wordier than usual with them. We've already touched on this, that we need to promote telehealth throughout the entire practice. And unless everyone in your setting, your practice setting, your hospital setting knows that telehealth is an option, it's probably, you're not going to really build your program. So we need to make our patients aware that telehealth is something that they may want to have a visit using this piece of technology. We need to remind our patients that routine care is important. And we all read what was happening during this past year of our patients didn't come in for primary care because they were afraid of the virus. They were afraid of catching the virus. So regular care didn't happen, regular care that could have occurred through telehealth. Again, when someone is calling for a visit, that front desk needs to know that this is an option. They've been taught and they have protocols in place so that they're not offering it to everyone, but they're offering it to the right diagnosis and to the right patient problem. We have to help our patients understand what telehealth is. I've heard particularly from geriatric populations that, you know, I really don't want to do it. I think it's a phone call. I think it's a lazy way for my provider to, I don't know if any of you have heard this, but I have. It's a lazy way to provide care, and gosh, I still have to pay for it. That doesn't make sense. So it's our job to talk to our patients about what this is and what the benefits are. We also need to let them know how to schedule this type of visit. Is it through a portal, for example? Some of us have portal. Some of us are still using a patient scheduler for the televisit scheduling. Next slide, please. A key component is what kind of technology do they have? We know smartphones, visits can happen off of smartphones, but they can't happen off of a track phone. You know, so when you ask a patient, do you have a device? You have to ask, do they have a camera? Do they have a microphone? If you have a platform where portals are sent out to them through email, some are still using email. If you're using Zoom, they get that through an email, not necessarily through an app. Some patients don't have emails, so you might have to resolve all of that before the visit. Somebody in your staff should be there to help them set up the email. Do they do a Google email, or how do they do an email? Think about some of your patients that aren't really tech savvy. Do they have a good internet connection? And if they think they have a good internet connection, we should probably test that before the visit. During that visit, remind them to have any family member refraining from streaming. Don't watch videos. Don't let the son downstairs game while the visit is happening. because that could affect the connection. Have them turn off all of their other running apps on their computer during the visit. For our individuals that don't have Wi-Fi connection, this is where we really need to start thinking out of the box now and in the future. I heard a great presentation yesterday, and they were talking about potential pop-up telehealth places for patients to go. But right now, it could be a library, it could be a park, it could be a community center that has Wi-Fi. Certainly during the pandemic, when you couldn't get into a library, that wasn't an option. But now it might be. Next slide, please. Another very important part of this visit is, and we've talked about it already, is there should be a staff member that can walk a patient through the setup of this visit. It's not going to be you, the busy provider. You're seeing patient to patient to patient. This is the team. Help them install the software. Help them perhaps update the browser. I am not an IT expert, and I've learned from Odie, who's on this call, more about IT than I ever wanted to know. So bring in your IT experts. Bring in people that, if you don't know how to do this, they can teach you how to do it and teach that scheduler how to walk a patient through this type of setup of the technology. Confirm that they know how to open the platform. Is the platform going to come to them through the patient portal? Is it going to come from an email? Is it going to come from a text? We talked about this already. A lot of these platforms walk them through checking the camera, checking the audio. Have them do that and remind them to do that before each visit. The apps, I can tell you from a personal experience, I have a counselor that I go to regularly. She shifted over to telehealth at the beginning of the pandemic, and she used DoxyMe. Had never used DoxyMe before. She sent it to me on my phone. So I opened it up from my phone app, but she never said, hey, you might want to save that. I mean, I knew to save it. I knew what to do with it, but and I've thought frequently, what are her other clients doing with this app? Are they digging through her text to find it each time? So we should help our patients set up the shortcuts and set up the bookmarks for this. Discuss how you're going to share the actual appointment and what it's going to look like. Going back to the etiquette of a visit, they need to know that this visit is just like any visit that would happen in person. Sometimes I found that patients will come on to a visit, and I would love feedback. They think it's more social. So they hop on, and they're used to FaceTime now, and they're used to FaceTiming their kids and their friends, and they may just start this social encounter rather than being ready for a medical encounter. So we need to prepare them for this type of visit. And it might be easy and best to do a simulated visit with this patient from beginning to end, a 5-minute simulated beginning to end with one of your office staff before they ever have their first visit with you. Next slide, please. Another thing is to prepare for the visit. So think about yourself when you started doing telehealth visits. I find that we all get kind of jumbled in our head, and what you're used to with regards to your beginning, your middle, your end of the visit often gets lost. That happens to your patients as well. So we need to remind them, one, to show up early, 15 minutes early. They would come to your visit in person 15 minutes early. Remind them to make a list of questions, because they will forget those questions when they come into this virtual encounter. Not only are they making a list of questions, but they should be written down, and ask them to have those questions next to them, where they can also take notes as you're talking to them through this virtual visit. They should bring with them for this encounter any medications that you've prescribed, both new meds and perhaps meds that they are taking with regards to vitamins and whatnot. So they're not running around the house. And if you ask them, what meds are you on, they may not remember. So they should have them all in front of them. Any medical devices that they've been using. We've talked about oximeters. We've talked about blood pressure cuffs. Remind them to have them with them at the start of this visit. Things like flashlights will help you look into their throat. Tape measures if they've got any type of edema, so that they can measure their calf with you, show you their pitting edema while you're in this visit. But you don't want them running around once this encounter starts. That was a great example of how to do an abdominal assessment with another person in the home. So if you know you're going into this visit with a patient and another person would be helpful, before the visit, say, have somebody with you so that they can help me do your physical exam. Have them plan for the amount of time that you have with them. If this is a 15-minute visit, they should know at the start of the visit, we have 15 minutes together today. So that just like you plan your visit, the beginning, the middle, the end, they can plan their visit with you as well. You may need to remind them that this is a visit like an in-person visit, and if they had a copay and you're not collecting that copay at the start of this encounter, that they will be billed for a copay just like they would for an in-person visit. During the visit, again, confirm the reason for the visit and remind them or ask them if they've had a consent, or remind them that there is a consent on file and are they ready to move forward with a virtual visit. Again, I said, let them know about the flow and the timeline. And it's important, just like in an in-person visit, that they have whatever printed material that you had given them, maybe at discharge or at the last visit, that they've got that in front of them. Some of the things I like to think of with our patients in preparing them is think about their learning style. It's not necessarily for everyone to have printed material. So can you send them a video? How are we teaching them? We need to be creative about how we're preparing them. It might be a 1-minute video. It might be printed material. We need to be prepared for all aspects of learning. Next slide, please. Troubleshooting. Troubleshooting is key. We've already talked about this. We need to, however, prepare our patients for that troubleshooting before the visit. Restart. If you go in 15 minutes early and something's wrong with your connection and your audio is not working and your video is not working, check your mute, check your camera, reboot, restart. Check your internet connection, close your applications. These are all tips that should be sent to them ahead of time so that they don't have to do that reboot that we all know of where the video is not working, we have to hang up, and it goes to a phone call. And those instructions should be provided differently for someone who's on a PC versus a Mac or a mobile device. Next slide, please. Etiquette for patients. It's key. They, like our new providers, don't know the right way to have a lighting source. So just like the provider with the lighting source not behind them, we need to talk to them about good lighting. Privacy, we've already discussed that. Background. I would say whatever you have behind you, remember your provider is going to see that. Treat it like an appointment. In our pediatric setting, we've got a pain and palliative care program running, and our physician providers said, wow, it's crazy. They'll be wearing their pajamas. They'll be laying in bed. So we do need to remind our patients that while this is really very casual, it's still a visit with the provider, and come as though you would for an in-person visit. Minors, we've had this happen where the parents are divorced or separated and the visit for the child occurs, the mother signs on and the child's with the dad. So we need to remind for caregivers that are caring for older adults or children that if the visit is for that minor, the minor needs to be there for the visit. Next slide, please. So I'm not going to dig deep into this. This is more, I'd like to have conversations about this. We have other considerations. What do we do for our patients that have limited English proficiency? How we should assess that before the visit. We have to have our medical interpreters ahead of time. And this is a great way to match providers to patients, because in this virtual setting, you don't need to be in the same practice with a patient that has a limited English proficiency, we could be reaching out to another provider in another area of the state. Our older patients, they have hearing and vision challenges. What are we going to do to prepare those patients for this visit? They may have a very low skill and a low comfort level with technology. Let's think about the support that we're going to offer them and how we can assess that before the visit. Our ADA, our patients with disabilities, they too need to have the opportunity to have excellent telehealth encounters. We must provide equal access to these patients. We need to also support them before, during, and after, and think creatively about how we are going to prepare and deliver telehealth to these individuals and educate them about the option of telehealth and to prepare them for the encounter. So with that, next slide. Let's open this up for discussion.
Thank you, Tina, for that great presentation. Again, the one person that too often gets forgotten in a telehealth encounter, the patient, the caregiver, to make sure it goes smoothly, and something we've definitely got to consider. So how do we get this information to practices so that they know that this has to happen? And how can we make sure it happens within the practices once we decide we need a better way of informing the patients?
Is that me or anyone else?
Go for it, Tina.
It's a team sport. I mean, everybody needs to be aware of preparing the patient. And I don't believe that it lands on the lap of the provider, whether that's a APP or a physician. We need to start at the front when it's scheduled and information is sent to them. Your nurse in a practice, I think it was Angela who spoke about the nurse rooms, or Anita, nurses room patients all the time for visits. This is a different rooming. When you room a patient for a telehealth encounter is when we can make sure that everything is up and running and that they've gotten ahead of time, either in print or video, how to do this type of visit. I think too often we forget about the patients that are limited English proficiency or low literacy, that they need to see this in a video and not in a handout.
I'm curious from the patient's perspective. Anita, you had a number of telehealth visits. Were you given information or provided much direction prior to the visit? And if so, what type things did you find beneficial?
Because of the way we quickly pivoted, the information I was given and the one I would consider good, I had a call ahead of time. It was explaining to me what they were going to do, that they were going to connect ahead of time, and how they were planning on having me see the number of practitioners who were on the team. It was the beginning, but that was the only scenario that I had that. Everywhere else, you were just kind of, it was me saying, I'm not coming in. This is not, I don't need to come in. I don't need to be exposed. And they, again, part of the approach with the bad and the ugly was their resistance, reluctance, choose a term, to actually embrace this as something more than a one and done.
Mm-hmm. And what about the others of you? Any experience or any sort of takeaways that you would like to share with the audience?
I think I just wanted to highlight some of the things that Tina said, especially in the other considerations. We really forget about the barriers to access for some of our patients. And we do have ways to do that. We just need to be mindful of it, and we need to make sure that we are catering to that population. Something as simple as making sure that there's a three-way connection for an interpreter or something like that. It's something that we might think of in an in-person and not so much in a telehealth visit, but it's absolutely possible.
Right. And part of that is in the preparation and the asking.
Okay.
And I think another thing that Tina said very specifically, which was fun, is everyone is now so comfortable being on video and being so casual about it, whether that be the patient or the provider. And I can tell you the numerous times that the patients are calling in from in their bed without appropriate clothes on, or just, you know, all of the possibilities that you could think of. And so establishing ground rules that this is still a visit with your medical provider. And I know there's the comfort of your home involved, but think about what you would be wearing or doing when you came into the office. Please try to emulate that as well. I think setting ground rules is a fantastic idea.
Mm-hmm.
So, you know, a lot of this deals with what do you do before you get online with the patient. Right at the very beginning, I know Tina touched on a couple things, but really making sure the patient is in the right mindset for the visit, so it's satisfactory for both of you. What are some things that you can do to help make that happen?
I think at the end of a previous visit is to remind them to have their notes ready for the next, and to remind them to have their medications and their devices, and also when they sign on and you have your nurse logging them in, or your med tech logging them in, it's another reminder. Because we're all busy. How many times do we forget something? We all forget something. I mean, I was doing a virtual visit with my vet. I mean, yeah, they're doing it now. And I logged off and was like, oh my gosh, I forgot to ask this. And so I needed the reminder, do you have your questions with you? So that I would ask all of them. So we shouldn't take anything for granted. I think sometimes we take our established patients for granted more than those pop in and a one and done. And we need to remind them and help to guide them through this new journey.
I know one of the things, you know, like with the situation with my son where he waited for 2 hours, physicians even, or providers, even face-to-face, sometimes have a hard time staying on time. And that's something that I have heard a lot of frustration about from the patient side, and even providers saying, I just can't get it done in time. And so several strategies I know that have been implemented there is, one, making sure you're clear at the beginning of the visit what the visit's for, what's going to happen during the visit, how long you have, and that after 30 minutes, the visit's over, or however long. And, you know, if you can't get through everything, you'll have to schedule another visit. So I think keeping those structures as part of it is something else to add. We've got a question. Go ahead.
I would like to make a suggestion that when you're waiting for a provider in a practice and you wait that 2 hours, you're sitting there waiting. It happens. When you're in telehealth, somebody, that first person who's checked them in, can say, you know, provider so-and-so is running late today. We realize you're at home. Can I have your phone number? And we will text you when we're 15 minutes prior to the appointment for you to come back in. You've given that patient 2 hours back of their day that they would have driven 30 minutes, sat another 2 hours, and then had the visit. I think you're going to have a very happy client if you manage it that way, versus just hanging out in virtual land, not knowing what's going to happen.
Yeah, excellent point. Someone posted, setting up the technology for patient, is this a billable service? Does it matter who does it before it can be billed?
Do you mean remote patient monitoring technology, or I'm not sure?
I think preparing for a visit.
No, it's the visit that's billed.
Okay, other question. Does anybody else have anything to put in the chat?
But I would argue back to that question. You don't bill your your nurse or the nurse or the tech doesn't bill the rooming of the patient. It's part of the practice overhead. It's the same bundle of cost.
Oh, this was interesting. Somebody, and Shruti put this up. I thought this was great. One of my favorite anecdotes, we tried to troubleshoot video for a very long time for a black screen and eventually realized the patient was just sitting in a dark room because the light hurt her.
It's just so fun because you were talking about lighting and it reminded me of the story. And it was so good. We finally realized, we were like, okay, for every other patient going forward, I'm going to say, is the light on in your room, or are you sitting under a blanket, or whatever
Tina
other possibilities.
Tina had a similar situation where they had put a Post-it over the camera in between.
Yeah.
Security people.
It's the old security where they can't see you if you put a Post-it on there.
Yeah. We were talking about the problems when you're going into people's home, but remember there are also advantages. The VA has been using for quite some time using telehealth for PTSD, for agoraphobia, and so many other things that they've had phenomenal response because of doing it. And my sister is an LCSW, and she works with adolescents and children, and there are those that they literally would have to be drugged into the office, and now you can hand them an iPad. Okay, they're under the table, but you can hand them an iPad, and you get to have the interaction in lieu of none. So there are, it's a mixed thing here.
I absolutely agree with you. There's so many advantages. One of our family medicine practitioners who specializes in young adults with developmental disabilities talks about how these telehealth visits work so much better for her because it's so difficult to extract them from their home and get them to the visits, and they can have these visits at home where they're comfortable, where they're comfort people, objects, things are around them, and they get so much information out of it. So you're totally right. It's such an advantage to a great number of patients.
And think of the conversation starter you can have. Show me your room.
Yeah.
Okay.
Or
your
cat.
We're coming on the 4 o'clock timeline. I want to thank the panel for an excellent discussion today. I want to remind people that there are a number of resources on our own Matrix site that respond to some of the topics that we have discussed today. So go there, see what Matrix has to offer, because they are doing an excellent job of reaching out and trying to provide the needed resources. And I'm wondering, Kathy, do you have any closing items?
No closing remarks other than, thank you all for joining us. We feel free to stick around in the Remo room to do a little networking. That's why we created the space, and we look forward to seeing you at the start of our summit.
Thank you very much.
Thanks, everybody.